Bismillah ar-Rahman Eosinophilic granulomatosis with polyangitis, which previously called churgstrauss syndrome. The definition and epidemiology of eosinophilic granulomatosis with polyangitis. There is asthma, blood eosinophilia, and an eosinophilic granulomatous inflammation of the respiratory tract with necrotizing vasculitis affecting small and medium-sized vessels. It is a rare syndrome. The incidence is 2.4 per million population, but 64 per million of an asthmatic population who may have been misdiagnosed with asthma. The age the disease occurs in middle-aged adults. The sex predominance. The male to female ratio is 2 to 1. The cause is unknown. A Montello cast was postulated as a possible cause, but this is now thought unlikely. Development of eosinophilic granulomatosis with polyangitis (EGPA) in people on Montello cast properly related to their decreased steroid dose, unmasking EGPA as a part of an increasing treatment regime in those with uncontrolled asthma, later diagnosed as AGPA. The clinical picture of eosinophilic granulomatosis with polyangitis include the following: asthma, blood eosinophilia more than 10%, vasculitic neuropathy such as Monin-Wright's multiplex, sinus disease, pulmonary infiltrates, extravascular eosinophils on biopsy findings, also may have myocytes and cardiac failure, cardiomyopathy, coronary artery inflammation, pericardial effusion, eosinophilic infiltrations of the mesenteric vessels causing gastrointestinal GI disturbance, alveolar hemorrhage, rarely proteinuria caused by renal disease with focal segmental glomerulonephritis. Renal failure is rare. Skin nodules and purpura, myalgia and arthralgia, fever and weight loss. Typical pattern of disease has three phases, beginning with asthma, then developing blood and tissue eosinophilia, then going on to systemic vasculitis. The asthma precedes the vasculitis, often by years. So the diagnosis of eosinophilic granulomatosis polyangiitis can be made if four of the following six criteria are present, according to American College of Rheumatology criteria in 1990. Asthma, blood eosinophilia more than 10%, vasculitic neuropathy such as Monin-Wright's multiplex, pulmonary infiltrates, sinus disease, extravascular eosinophils on biopsy finding, and also may have myocytes and cardiac failure, and cardiomyopathy, pericardial effusion, coronary artery inflammation, may have also eosinophilic infiltration of mesenteric vessels causing gastrointestinal disturbance, alveolar hemorrhage, rarely proteinuria caused by renal disease with focal segmental glomerulonephritis, and renal failure is rare, skin nodules and purpura, myalgia and arthralgia, and fever and weight loss. Investigations of eosinophilic granulomatosis with polyangiitis, the churgstrauss syndrome, include the following: chest X-ray, which may reveal fleeting peripheral pulmonary infiltrates and bilateral multifocal consolidation, the HRCT, which may reveal ground glass inflammation, pulmonary dues, bronchial wall thickening or alveolar hemorrhage, bronchoscopy, which by bronchoalveolar lavage may reveal marked eosinophilia. Pathology: extravascular tissue eosinophilia, necrotizing angiitis, and granulomata. Serum markers: there are peripheral blood eosinophilia, perinuclear ANCA, and anti-MPO positive in two-thirds. ANCA levels may not correlate with disease activity, but blood eosinophilia is a good guide. The diagnosis: predominantly clinical diagnosis, pathological confirmation of eosinophilic tissue infiltrates or vasculitis desirable, and the biopsy: easiest site affected, such as skin, kidney, or open or thoracic or thoracoscopic lung biopsy. Differential diagnosis of eosinophilic granulomatosis with polyangiitis include allergic bronchopulmonary aspergillosis, sarcoidosis, drug and parasitic cause of eosinophilic pneumonias, hypersensitivity pneumonitis, hypereosinophilic syndrome. The management of eosinophilic granulomatosis with polyangiitis include the following. If isolated pulmonary disease, oral prednisolone 1 mg per kg, maximum 60 mg per day for 1 month or until no evidence of the disease, then slowly decrease over 1 year with increase if symptoms recur. If the patient is unwell or with alveolar hemorrhage, pulsed methyl prednisolone IV for 3 days, followed by high dose oral steroids with or without cyclophosphamide. And in cardiac or gastrointestinal disease, relapse, or life threatening situations such as requiring organ support, cyclophosphamide should be added. The plasma exchange is of no benefit. Treatment is aimed at reversing organ damage and reducing relapse rate. And to maintain remission, prednisolone and one other immunosuppressant drug are usually required. Cyclophosphamide is often changed to azathioprine after 4 to 6 months. Prophylactic cotrimoxazole should be given 960 mg 3 times per week or 3 days per week, and consider bone protection for steroids. Follow up regularly with checks on full blood count and eosinophils count and doing chest x-ray. Mepolizumab, an anti-interleukocyte 5 monoclonal antibody therapy licensed in eosinophilic asthma, has shown some efficacy in an early study for eosinophilic granulomatosis with polyangiitis, and further studies are underway. The prognosis of eosinophilic granulomatosis with polyangiitis, the churgstrauss syndrome, is good prognosis if isolated pulmonary disease, good response to steroids, and may continue to have asthma despite control of vasculitis, which can be severe and difficult to control. Poor prognosis associated with cardiac disease and severe gastrointestinal disease causing bleeding, perforation, or necrosis. Untreated 5-year survival rate is 25%, also associated with worse prognosis. Proteinuria, more than 1 gram per 24 hour, renal insufficiency, and CNS involvement. Cardiac disease is the main cause of this. That's all about eosinophilic granulomatosis with polyangiitis, Churg-Strauss syndrome, and thank you.